Yeah, so hello, my name is Richard McManus. I am a GP by training. I'm a professor of primary care and I am the Dean at Brighton and Sussex Medical School. Yeah, so I qualified from what was St Mary's Hospital Medical School, which is now part of Imperial College, in 1991. And I started off doing a couple of years of SHO medical training, and then decided that actually I wanted to be a GP. So transferred over to a GP training scheme, which I did in Gloucester and Cheltenham. Uh, Along the way, I'd done a intercalated BSc at medical school, and at the end of my GP training, I decided I wanted to do some more research. And then I moved to the University of Birmingham, where I had a clinical research fellow job, and I did a master's, followed by gaining what was a precursor to NIHR funding for my PhD, having become interested in self-monitoring of blood pressure and cardiovascular prevention in general. So I did the first UK trial of self-monitoring for my PhD, self-monitoring in hypertension, and then moved on to a postdoctoral research fellowship with NIHR that I did the world first trial of self-management in hypertension, so getting people to measure their own blood pressure and adjust their own medication. And then I got an NIHR career, I think it was called a career development fellowship. They don't exist, equivalent of an advanced fellowship in today's money, and did further trials on self-monitoring. And then eventually I got an NIHR research professorship, having moved from Birmingham to Oxford in 2011, and carried on with my research in self-monitoring, expanding it into the field of obstetrics and starting a successful collaboration with Professor Lucy Chappell, who I know has got one of these interviews as well and currently runs the NIHR herself. And now I'm an NIHR senior investigator and moved earlier last year to from Oxford, from a research professor job in Oxford, to become the Dean at Brighton and Sussex Medical School, the third Dean and the first Dean here to be a GP by background. Certainly the appeal for me was the ability to mix and match. So to mix an ongoing clinical workload. I'm still a rather part-time GP, but until August of last year, I was a partner in a GP practice in Oxford. So you can have a fairly full-on clinical role, but in addition to that, perhaps the majority of my job for the past 20 years has been doing research, and then more recently some of the leadership that comes around research. And I think medicine is fairly unique in allowing one to hold those two, both the clinical role and the academic role, together. And I think they both feed off each other. So one can gain research ideas and also implement research results in one's clinical role. And then in terms of the research role, seeing patients is very good for understanding what's important. Well, I think that all the evidence suggests that people who take part in research generally have at least, if not better, outcomes than patients who do not. I think having a research-informed clinician can give other opportunities that might not have otherwise been available for an individual to take part in research, or to indeed become involved in research. Some of my patients have become patient representatives, for example. I think also it gives you a particular way of thinking, and I realise that evidence-based medicine is quite an old hat thing now, but certainly when I started, the approach of understanding evidence and being able to understand when patients want to talk to you about something new quickly, and be able to evaluate that has been very helpful. I think also that in terms of things like CPD, because you're going to conferences and hearing about the latest things, it does mean that it's relatively easy to keep well informed, at least in the area that you're researching. Well, I think the greatest challenge is usually the juggling effect that one has to do. So, as well as for clinicians who just do clinical work, they can do often a certain amount of research and or teaching and or leadership in their role. But essentially, they've got one thing to do, which is to deliver a clinical service. Whereas if you're trying to combine delivering a clinical service with working as a university academic, getting grants, teaching medical students, potentially doing some leadership roles, then it is rather more juggling. I think in a long career, then say it takes 10 or 15 years to get to a consultant role, or perhaps less than that to get to be a GP, you quite quickly get into a rut if you're not careful of what the clinical role is like, and you get after you've been doing it for 5 or 10 years, you understand what that particular day job is, and what the academic side allows you to do is to have a different aspect of your career that can both inform the clinical side, can feed off it as well, to hopefully maintain enthusiasm and enjoyment over a long career. So my research is largely based in terms of cardiovascular prevention, and it usually involves working in relatively large multidisciplinary teams, which will involve both people who do trials, so trialists, statisticians, nurses, and other healthcare professionals like midwives. It will involve health economists, social scientists, and public health doctors, as well as more clinical doctors. It usually involves both primary care and secondary care. And what that means is that I'm used to working in a very large multidisciplinary team. I'm also used to managing people in that multidisciplinary team, and management has become more and more of a thing in primary care, whereas historically doctors used to work on their own. They're now much more likely to be working in teams in primary care. But what it means that when I see a patient is that all that experience I've got can be brought to bear in my 10-minute slot that I have as a GP to see a patient. And I can hopefully use those additional skills that I've gained from my clinical academic work to have, as I say, an evidence-based approach, but also a very multidisciplinary approach. So I think I've been lucky to have different mentors along the way. I was first recruited at Birmingham by Professor Richard Hobbs and Professor Kate Thomas. Kate is now the dean at Birmingham. Richard Hobbs is professor and head, and most recently head of department in Oxford. They were responsible for nurturing me to start with. I then have had a very long mentoring relationship with Professor Jonathan Mant, who is at Cambridge University. We were both at Birmingham. He was my PhD supervisor, who I would credit with teaching me what I call the game of research. In other words, understanding where the bar is, what one has to do, what the levers are to gain research funding, and what being successful looks like. And Jonathan and I worked together for a very long time. And then I guess for the last 10 years or so, as one becomes more senior, mentors perhaps become more like collaborators. And I would say that Lucy Chappell, who many of you know as leading the NIHR, as a researcher in obstetrics and a trialist in obstetrics, has been a very big influence on me in moving from a largely primary care based research portfolio into one that straddles the primary secondary care interface. I'm absolutely passionate about trying to bring people into clinical academia as a whole, but also into clinical academia with regard to primary care. I think that a key thing there is supporting colleagues, and I have a group of somewhere between 5 and 10 people who have different levels of contact with me through the year, who I would advise in terms of applying for fellowships at different levels, about research things, sometimes about basic stuff like how can you be a partner in a practice and carrying on doing research? How do you organize your week? How can one maintain a reasonable work-life balance? And I think this is really important. And certainly in my last few years at Oxford, we were able to support members of my team or people allied to my team to get fellowships from NIHR in terms of medicine, also in terms of midwifery, wider things like the British Council and climate change, and just generally providing a supportive environment and making it normal for people to do work that is designed to improve their own career as well as delivering whatever project is that that person may be working on. But I'm really keen on this and really keen that my colleagues and now the people that work at Brighton and Sussex Medical School have got a good reputation for this. So I think that the situation now in training for medics in particular and also for healthcare professionals in other specialties has been revolutionized by the impact of academic training schemes. So, for example, in 1997, when I qualified as a GP and was looking for a training scheme, there just were not any really formally anywhere in the country, apart from possibly one in London. The one that I ended up managing to get onto in Birmingham was a one-off. So the first thing to say is that there are lots of opportunities. Look for those academic posts in foundation years and then at ACF level. But in looking at those, you need, as I say, to understand what the game is, what you have to do, and so the way that you do that is to talk to people. I think most university clinical academic departments will have people who are working there who would be very happy to talk to prospective newcomers. As a medical student, there are often small projects that one can get involved with either formally as part of the course. So at BSMS at Brighton and Sussex, we've got research projects that students do in their fourth year, but that's a formal thing. You can do informal projects, and I've had several medical students work with me personally doing informal projects. Find out a bit more about it, get onto some of these gateway fellowships. Ultimately, if you do want to do an academic career, you'll usually need to get a PhD, and that means getting PhD funding. And so funders like NHR and Wellcome and MRC and some of the big research charities like Cancer Research or British Heart Foundation have schemes that fund PhDs. And find something that you're interested in, find a mentor stroke supervisor who you're happy to work with and go from there. But I think most of all, don't be afraid of it. We're all normal individuals. I think when I go back to reunions at my medical school, people to start with were quite surprised that Richard McManus turned out to be a professor. So just because you weren't marked out as a particularly academic person at medical school, if you're interested in it and you've got the basic enthusiasm, that will take you a long way. Certainly has in my case. So I think that this is an interesting problem and one where there does appear to be quite a fall off at the point where people go and get their PhDs. So in many specialties outside of general practice, clinical academic colleagues will be doing their PhDs alongside their specialist training. and within their specialist training. Whereas for GPs, if you're lucky enough to get on an academic clinical fellowship scheme, that spits you out at the point that you gain your primary specialist qualification in general practice. And so you're then faced with looking for PhD funding at the same time as being a newly independent GP. And I think we need to think about how to try and support people at that point, because many colleagues feel that they're not ready to go straight into a full-time academic role whilst trying to take their first steps as an independent clinician, as a GP. And I think that is one of the key reasons that there's such a fall off. So I would be in favour of looking at schemes that allow a longer ACF, maybe going straight into a PhD while you're doing it. I think that there are clear problems with that in terms of funding, because the funding for doing a PhD is usually rather less than the funding for going and being a GP. So that requires both funders and individuals to take a long view on what's possible. I think some of it is also thinking about institutions. So we find ourselves having roughly half of graduates end up in primary care as GPs, even if they don't start off doing that. And yet there are structural issues in most medical schools where the part of the course is devoted to general practice tends to be relatively small, and therefore the people delivering that course are often relatively small. There are huge variations from place to place, however, and so it's not impossible to increase that. I think that overall we've got roughly 400 or 450, something like that, clinical academics in GP, and something like 45,000 GPs in the country. So the numbers are very small. So there is a long way to go, and those numbers have been pretty flat, probably reflecting the fact that the number of GPs has been flat to falling despite efforts to increase those. So it's not at all straightforward, but I think the key thing is concentrating at the point where people are going potentially to do a PhD and trying to hang on to them and keep them within the profession at that point.